I think of MRI scans as the gateway drug, and it's the vulnerable people. And so they take this diagnosis to heart and their life trajectory changes.
Hello, I'm Mariam Tadros of iCare, and today I am delighted to be joined by Tanya Cambey and Dr. Mary Wyatt. These two ladies are speaking to us today around the unintended consequences of clinical care in personal injury schemes. This session is part of the issues stream at the PIEF 2025 conference and has been sponsored by CIRA. Dr. Mary Wyatt is an occupational therapist who is active in policy development and research. Her focus interest is in getting research into practice, demonstrated by the It Pays to Care model, bringing evidence-informed practice to work injury schemes to help workers and their workplaces. And Tanya has over 20 years of leadership experience in the personal injury sector, bringing deep expertise in healthcare strategies, customer management, and system improvement. Tanya is currently looking after the WorkCover Queensland medical strategy and is known for her outcomes-based practical approach to enhancing recovery and service quality in complex systems. Ladies, welcome to each of you.
Thank you.
Thanks, Mariam.
Great to be here.
Quite an impressive bio from each of you, and the common thread that I see with the pair of you is this really keen interest in bringing demonstrated evidence-based approaches into a really grassroots way, a practical way of supporting people when they need it most. So I can understand why you all get along so very well, because you certainly have got the same ethos and the same approach to personal injury, which is wonderful. Now, your presentation is largely focused on that time, that real momentous time in the personal injury journey where you need to be thinking about early interventions, you need to be thinking about practical supports and all of the elements that are in that person's ecosystem of their recovery journey. And in your presentation, you show biopsychosocial screening, like the Cerebro questionnaire, that can identify who actually needs intensive support early. And that seems straightforward. Why isn't it standard practice?
Well, realistically, it should be. The evidence is very clear that if we can identify those risks early and offer that support early, we get the better outcomes. Workers, when they're in high distress, in fear avoidance, and having that poor social support, they need that help. And it's our job to make sure that we can connect them with those resources. If we start using those screening tools from day one, we can reduce the long-term disability. We can get better outcomes for those workers, and we can also ensure that we actually are giving them the servicing that they need. 70% of people will recover with limited intervention required. So it's the remaining 30% that really need our help, and that's where that tool can really help us hone in for those that need that support and make sure that we're actually allocating those resources efficiently.
And if it's a smaller portion that are needing that in-depth support, that's the smaller portion that's deeply challenged by their recovery journey. What's your concepts on what happens when we don't offer that support to that cohort that need it most? What are the downstreams of doing that?
In our presentation, we talked to Will's story, and unfortunately, Will's story is not an isolated story. And it shows that if we don't pick up those flags and intervene at the right time and offer that support, it can have catastrophic consequences. Will actually, unfortunately, took his life, because he was a young, fit worker, hurt himself, and then unfortunately it was just compounding challenge after challenge, flag after flag missed. And it's a horrendously sad story, but unfortunately it's not an isolated story across our schemes. So we have a responsibility to make sure that we pick these flags up and offer those supports to people.
Tanya, you mentioned Will, who was the young worker in a regional area. He was flagged as MM3 on the modified Monash scale. And how much does his story, I suppose, impact the way in which we think? And how much does the postcode determine the outcomes in compensation?
Yeah, great question. So realistically, your geography is your destiny. If you look at the Australian health and welfare data, the number of services and specialists in rural and remote areas is very different to the metropolitan corner. If we look at specialists per 100,000 population here in the metropolitan areas, it's about 147 specialists. And it takes around about 2 to 3 weeks to get an appointment. But if we look at those that live in the rural and remote areas, and unfortunately Australia is a very large area and has a large geography, in the rural and remote areas per 100,000, you only get about 18 specialists per that population. And then the average time to get an appointment with that specialist is anywhere up to 7 months. There are some areas where they only have one specialist in town. So the postcode matters. We call it the treatment lottery. You can have 2 different workers, one in the metropolitan corner, or like Will, living and working in a rural and a remote area. And their access to services is really disparate. It's really scary. And it's, then not just the access to the GP, it's the access to the allied health services. It's the access to, getting to the local pool to be able to do fitness. It's a compounding issue. So, it really does make a big difference, and it shouldn't. We need to make sure that we can try and, make everyone gets access to the services that they need. So it's really, really, really challenging for schemes. And if we think about, what that then means in terms of just that delay and that compounding issue where, we miss that opportunity, like the Arebro says, to pick up the risks and intervene early. So
When you said your geography is your destiny, my goose pimples came up, because if all it was the geography, that could have meant the difference for Will in having and continuing a productive life versus feeling so overwhelmed with his injury that there was no way forward. It just seems a catastrophic loss, that there's not more that can be done. And in the absence of being able to attract more physicians and specialists to a rural area, in that waiting game that they have, which is extensive, surely there are other, even smaller, more attainable interventions that can be put in place to support people and to support their psychological health in the waiting.
There's a lot of innovation happening in terms of, those digital early intervention programs, the exercise programs that you can get through the various apps. We as insurers and as regulators have a responsibility to open our minds. We're used to that conventional treatment model, right? I see Mary gives me a diagnosis, I go off to, and get my treatment. We need to think laterally and make sure that, we get their engagement in the process too. Because if you're injured, the old hurt versus harm, your inherent nature is to stop because it is hurting. But we need to make sure that we keep that movement happening and keep that engagement happening, keep that autonomy and their recovery happening as well.
And you need a real cheerleader, by the sounds of it, to keep you going and to keep you motivated through your pain, so that you can work through and help yourself to recover, in the best way that is going to work for you. It's not necessarily about efficiency, but it is, by the sounds of it, and I'm not a physician, Mary, so please, jump in and let me know, but it is about consistency by the sounds of it. And if you don't have that impetus from within, you're going to need it.
Yeah, exactly. And it's how we all talk about the injury and how open we are, and then, the information that we're sharing and leveraging and working together. So that's really critical.
And in terms of talking and the language that we use and what we're saying, we have talked, and you have talked in your presentation, about the labels we want and the harm they do. What do you mean? Don't patients need diagnosis?
My part of the talk I've called the absurdity of medicine in workers' comp. And there really are a range of things that we do which are just crazy. So one of the common things, back problems, really common musculoskeletal problem we're dealing with, haven't been improving for a couple of weeks. What do we often do? A scan. So we all want a diagnosis. The patient wants it, we want it. So there's kind of standard things to do a scan. And the problem with that is that the scan comes back with results like degeneration and disc changes and disc bulges. And 70% of people have that on their scans without pain, which is fine. A lot of us know that, but the patient doesn't. So the patient hears degeneration, and then they become more distressed. And then there's this path, and I think of MRI scans as the gateway drug. and it's the vulnerable people. So it's the distressed people, the low self-efficacy, low health literacy. And so they take this diagnosis to heart and their life trajectory changes. The pain gets worse, they're more distressed, more interventions. People who are distressed are more likely to get more drugs, more opioids, more interventions. Surgery is way more likely. We've got a whole range of evidence that tells us how much harm scans can do. And I'm talking about it for back problems, but the same issue, epicondylitis, shoulder, same issues. We're picking up normal changes and pathologizing them. And then we compound that in many other ways, which we're talking about in the session. But this is just crazy what we're doing to people. And I see them at 3 years down the track and their lives are in really poor shape. They've, there might have been marriages broken down and they've lost their income and they've lost their role model and their identity. And no wonder they're depressed. So we do need to start talking about some of these deep, significant issues that people may not be aware of because we are doing a lot of harm.
So we're creating harm through diagnoses or perhaps over-diagnoses or coupling existing diagnoses with something that's not relatable. It could be other comorbidities that we're hanging about. I don't know if the word harmlessly is the right word, but certainly non-symptomatically. But the compounding psychological effect of then seeing yourself through the lenses of an unwell person has those irrevocable.
When I'm seeing, I do IMEs and people are often 2, 3, 4 years down the track and I have to make sure I keep my face not looking a bit aghast every time I hear someone say, and then they did the scan and then they saw the disc and then they realized how serious, and then they all realized how serious it was. And it's just such a common refrain. And you look back, what could have we done?
What do you think about in terms of that? Because part of our legislation, our requirements to qualify for compensation, for something to be compensable, you do need a level of diagnosis and you need to determine eligibility and liability. And so these tests and so forth are being requested often because it's part of satisfying the legislative requirement. It sounds like we need a bit more of a grassroots approach to this.
Absolutely. There's been a movement for 20 years to call back pain back pain. The best researchers in the world can't tell you what is the pain generator in back problems. So when we call it facet joint arthritis or a disc bulge or an annular tear, we don't know what we're talking about. It's actually, there's a back problem and we're better to call it, persistent back pain and talk about it as such, because just as you say, that quest for further investigations, etc., just causes harm in itself.
Now, something, just in the same vein around the systemic ecosystem in which we operate our schemes, you talk about how funding systems and business pressures drive doctors toward low-value care. And that sounds a bit harsh. Aren't doctors just trying to help, or?
I think by and large doctors are trying to help, and so is the industry is set up to help. But hey, we've got to check out what we're actually doing. And so if you think about the level of complexity, some of these vulnerable people will, and, in his mid-journey, that level of complexity. And then you think about general practice training. I was in general practice in the 90s. I remember the cases I had no idea what to do with and how to deal with them. So we have this huge complexity mismatch. And then the extra pressures, we've got GPs under enormous pressure, fewer people going into general practice land, people just struggling to get an appointment for an earache, which is a really simple thing to treat as a doctor. You love those consultations. They're quick, they're meaningful and they're simple. But then you've got this level of complexity. You've got the person on opioids and the workplace doesn't want them back and the claims person is perhaps not as responsive as needed. How can a GP deal with that? So and then we've got the corporatization of medicine. We've talked to practices about having receptionists take on this extra thing, but they say we can't give it to receptionists. They're staying back already because there's this pressure on the corporatization. There's KPIs, it's quick medicine. It's much quicker to order a test than to talk to the person. It's much quicker to refer than to actually try and deal with it yourself. And so we've got this very negative combination of complexity and insufficient skills and time. And the trend is not our friend. In medicine, we like to see the trends, the trend, the person's getting better. That's likely to continue. And the reverse. But we've got this trend that's not getting better, and I don't see it changing for the foreseeable future. So we need to be having some deep discussions and thinking differently.
And it sounds like we need to be approaching things differently.
Yes,
So
absolutely.
if the case is that trend of poorer or lower GP availability and care is going to continue and continue, which is only going to then force the disparity of the postcode scenario further, then we really do need to start thinking about how we're servicing community via different strategies, whether it is through employment of AI, whether it is through further GP training or community-centred allied health training. But also, I do like what you were saying, Mary, about calling a spade, not exacerbating injury. Just, yep, you have some back pain. If I hear I have a bit of back pain versus I've got a bulging disc, I'm going to feel very differently about that. I'm going to still see myself as a person capable of recovery.
Yep, exactly.
I'm not going to see myself as a person who perhaps needs strong painkillers, because a bulging disc sounds painful as it is.
It sounds quite catastrophic.
Yeah.
To the lay person, the average patient, absolutely.
Yes, absolutely. Yeah.
And just a call out to PIEF and what PIEF is doing in terms of training GPs. That's a long-term project. But it really, there's a lot of people with interest in this area and goodwill. And if we could support a more skilled workforce, particularly in general practice land, a lot to be said for that.
Yeah, absolutely. Well, I tell you, this has been a really insightful discussion. I want to thank you both sincerely for bringing your expertise and what you're seeing out in the field in a no-holds-barred approach, because we really need to have some candid discussions about the failings of our system, and that really just provides opportunity, right? It's not about finger pointing, but it's about saying these are the real issues out on the ground. How do we think about this differently? How do we challenge ourselves? And as key industry players, and we're all gathered here at PIEF 2025, coming from different sectors, jurisdictions, we're rehab providers, we're treaters, we're practitioners of all sorts. This is a great platform to be able to inspire that change and see what can be done.
Absolutely. It's our opportunity to get the coalition of the willing together.
Yeah, absolutely. Well, sign me up. I'm very willing.
Done.
Fantastic. And a call out to you, Marion, for all you're doing for case manager capability.
Thank you very much.
You're doing a great job.
Kind.